Dr. Chang has been the director of the UCSF Neuro-Oncology program for quite a long time. And she is a wonderful mentor and is really leading the way in programmatic development for caregivers and survivors and trying to address these cognitive issues with our patients across the disease trajectory. So she has developed the Survivorship program and the Caregiver program, of which we'll hear about today. And she's the director now of the supportive care services at UCSF, and she's going to be moderating our next session regarding developing programs for patients and caregivers. Thank you, Dr. Chang.
Thank you, Jenny, and congratulations to Chris and Sean and yourself for a wonderful symposium. In this session, we will review patient and caregiver perspectives on the impact of cognitive impairments on quality of life and review the components needed to build patient-facing clinical programs. Our focus is on how we can implement and integrate neurocognitive health into our clinical practice. I would like to introduce our team members. Naomi Hoffer is the program manager for the Sheri Sobrato Brisbane Brain Cancer Survivorship program, and she has been instrumental in developing great resources for our patients focused on wellness and community. Alexa Greenstein is a nurse practitioner in a neurocognitive clinic. She works closely with Chris and Melissa to evaluate emotional and cognitive health of our patients and provide rehabilitative strategies to improve their quality of life. And Margaretta Page is the co-director of the Gordon Murray Caregiver Program, and she leads the development of supportive and educational resources for the caregivers of our patients. So our team members will provide their experience on the building of programs that enhance the well-being of our patients and families with an emphasis on cognitive and behavioral health. These important programs were created to address the needs our patients and caregivers were experiencing in their brain tumor journey. And so in addition to our team, we're also so fortunate to have the opportunity to hear from one of our patients, Dieter, and his wife, Julie, who will share their story, their challenges, and their strategies that they found helpful to optimize their quality of life. Thank you.
Thank you so much, Julie and Dieter, for being here today and helping us understand what a brain tumor diagnosis and its effects might be like for both of you. So Dieter, can we start with you? Can you tell us a little bit about your history as it relates to your brain tumor diagnosis?
Yeah, so I've always had strange headaches, and I went to a headache specialist, and I went through the typical neurological exam that they do, and I guess I failed part of it. 2 weeks prior to finding out I had the tumor, I had decided the company I was working for got acquired, and I had made the decision to not go with them and instead do my own thing. Once I got the diagnosis, I was kind of on that course, and the surgeon said, "You'll be fine." And I think by his standard, I was, and I think it was fine. I just think that, because of how complicated my work is, I wasn't able to do my work. And I guess I thought fine was being able to do my work. And right after my surgery, we had the at-home nurse, I forget what it's called, the nursing program. They would come to our house and they tried to do some cognitive rehab, but it was 2 weeks after my surgery, and I was having trouble just speaking and just kind of getting about, and it wasn't right, and it left me frustrated, and I finally told them to stop coming.
Okay, and in terms of, you said you weren't fine in relation to your work. What did you notice about yourself? What was going on with you internally that felt different, that didn't feel fine?
Yeah, I would say for the first time in my life, I truly drew a blank. Mm-hmm. I would be in a stressful situation. I mean, and it was, in retrospect, it was kind of an absurd situation because I was pitching investors, and I went through a series of interviews, and I would truly draw a blank. And I don't mean draw a blank didn't know what to say, didn't really know where I was.
Mm-hmm. Wow. Yeah, that must have been scary for you and very different.
Yeah.
Yeah.
It was not ideal.
And Julie, can I ask you from your perspective, what did you notice and what was that like for you?
I think one of the main things I noticed, especially at first, was that he wasn't social, he wasn't extroverted. He didn't want to talk. And that was sort of a it was a big deal because it was one of his main qualities, like one of his personality qualities, and had been a way in which we were really compatible, where he was more the social one and I'm more introverted. And he had a lot of trouble at restaurants, for example, and would kind of freak out if we were in a restaurant. And part of that was the noise. Your hearing is really amplified, but also when multiple people were talking to him, that was a problem. And so it was sort of this cognitive shift that felt like a personality shift. And so that was like a really big thing that we were thinking about and talking about toward the beginning, but about 6 months after his surgery still. So that was when we started to kind of think, well, are you just recovering from surgery, or has there been a change here that we need to get checked out?
Well, thank you so much, Dr. Chang and Julie and Dieter, for sharing your experience. My name is Naomi Hoffer. It's such an honor to be here on this esteemed panel of researchers and clinicians. So my role at the UCSF Neuro-Oncology Department is a program manager. So I have come in to work with the team and help translate all of this wonderful research and knowledge that we know it will be helpful for patients, and translate it into a program and design a program at UCSF. So I wanted to just share with you some of the guiding principles that we have used in our development of a program. So first of all, it's really important, I believe, in an institution to recognize that the needs of brain tumor patients are unique from general cancer population needs. And I really have seen this firsthand, because before 2 years ago, before coming to work at the Neuro-Oncology Department, I worked for 17 years at the UCSF Helen Diller Family Comprehensive Cancer Center, and I developed supportive care programming for cancer patients, and we developed amazing programs. And I thought it was, fantastic programs, but I was always curious why we weren't seeing more neuro-oncology patients and caregivers, why it wasn't attracting that population. And it really wasn't until I came to the Neuro-Oncology Department and started really talking to our patient population that I realized why. So just recognizing that their needs are unique. And so specific programming is really helpful. So it's also really important to keep the mission and vision at the forefront of our minds. Sometimes you may, have experienced this. It's easy to get swayed by research needs and institution needs and reporting needs and donor needs. But if you keep the mission and vision at the forefront of your mind, that really, really helps when you're thinking about developing the programs. And in addition to that, as we heard from Dieter and Julie, it's really helpful to hear their voices all the way through in program development. So we like to take a patient-centered approach, and really involving their voice in all aspects of the planning phases, creating partnerships where we're constantly asking them for their feedback and evaluation. And what we did at the onset was we did a focus group, and we did many interviews with our survivors. So I wanted to share with you our mission statement that's really, we've kept our eye on. The mission of the Sheri Sobrato Brisbane Brain Cancer Survivorship Program is to enhance the wellness and quality of life of patients with brain tumors through a collaborative, multidimensional approach focusing on emotional, physical, and cognitive health. So for us, that means we're asking ourselves the question, what does it mean to live a great life with brain cancer? Not just survive, but live a great life. And then how can we support our patients in doing so? So we ask ourselves, what's it like for brain tumor patients when they try to get back to their life and live their life? And here's some of the things during our interviews and focus groups that we were hearing. I don't feel like me. No one understands what it's like. I wasn't prepared for this. I might look fine on the outside, but I'm screaming on the inside. I'm scared about my future. I'll probably never see retirement. So what does that mean for me living my life now? I'm searching for purpose. I don't want to be a forever patient. I want to be my healthiest self. I want to live like an outlier. I want to give back and help others. So you might notice from this, there's an interesting dichotomy where on the one hand, patients realize that they're kind of alone in this disease. They're feeling very isolated and they could really use some support. But on the other hand, they know their life might be cut short, and they're not wanting to live their lives as a forever patient. They don't want to always be just having that role. They want to live their lives fully. So it creates an interesting challenge for us, and one that I feel has really helped us deepen our understanding and broaden our understanding of what programming is like to support this population. So I'd like to share with you kind of what the pillars of our program that we've developed. So really, the Neurocognitive Clinic is the cornerstone. You heard Dr. Tumor and Dr. Bree talk about this clinic. But it was crucial to us that the support of our survivors didn't end with evaluation and diagnosis, that they deserved, and we really wanted them to have education, support, and rehabilitation as well. So it was really crucial that we found somebody like Dr. Jamora who had a background in TBI rehabilitation and that could really provide rehabilitation to our patients. And we're continuing to evolve our clinic, as you will hear more about in the coming presentation. So in addition to that, we also recognize that there could be multiple access points to supporting cognitive needs in our brain tumor patients. So we're really excited about this WOW program. Our WOW program includes an exercise physiologist who meets with patients or caregivers one-on-one and helps them develop a program to meet their individual needs. And this program also includes free or discounted gym memberships, as well as we're developing a Headstrong and a Headstrong Plus app that really supports brain health and emphasizes some cross-lateral movements that we know supports brain health. So we're excited about that aspect of our program. In addition, we have developed some educational resources, both written and in video format, that can serve to support cognitive strategies and wellness. So we have 11 cognitive strategies handouts that we can offer patients. We have a whole video library that has topics such as cognitive strategies, fatigue management, workplace balance, and things like that, that really also kind of come in and support patients, as well as nutrition. And it can provide more immediate support to our patient population because even those who are getting neurocognitive clinic support from our neuropsychologists might have to be on a wait list for a while. So this allows them to get some immediate support that clinicians can hand directly to our patients in the clinic, and they can access these online. In addition, we wanted to create opportunities for patients to learn together in a group setting. So we have webinars that we do, and we have an after the show component where they can talk together. We also have a regular integrative approaches class that really looks at nutrition, supplementation, and other integrative methods that support cognition, fatigue, and general health for brain tumor patients. And finally, we have heard from patients that it's difficult to live this disease and it can be very isolating. In addition, this population has gone through something extraordinary that probably very few if any of us on this call have gone through. They've gone through brain surgery. And so connecting with other people that have gone through it is crucial, I think, to a person's well-being. As much as you and I want to empathize and understand, there's really limits to our ability to understand what this is like from the inside of a patient's experience. So our peer support program offers opportunities for our survivors to meet each other and share strategies. And it also gives some meaning to this experience. Many can't work full-time anymore, and so have a desire to give, a desire to serve. And this is a really good opportunity for patients to serve and make meaning out of their experience. So we have a peer support community and we have a regular Thriver group that meet regularly. So now we'd like to hear again from Dieter and Julie how their experience was like with cognitive testing and cognitive rehabilitation. So I'm going to play the clip from them.
So yeah, we eventually decided to get him checked out.
And I think I needed those 6 months, to be honest. There was a lot of rejection in that 6 months for me professionally. And also I had Julie and I had my therapist, and just kind of working and doing that kind of work to put myself in a position where I was ready to, kind of accept that I had an issue. My career is being a data scientist. Having executive function, executive function disorder, and having that part operated on, I don't think I gave full credit to how bad that was going to be. I think that it didn't even occur to me how bad it was until, I took the test with Dr. Tumor and scored very low on certain things.
Tell me a little bit more about your work with cognitive testing and rehabilitation.
The results of the test were very convincing. It wasn't borderline what was being said, and and it was really helpful for me that, Dr. Jamora grounded it in the physiology, saying basically like this part, kind of connecting it to where the surgery was, because it's like we affected your brain in this way. We would expect this kind of effect, and we're seeing it. I think that was very convincing. I think that I was on board at that point. And I did the testing alone, obviously, because it's like a 3-hour test or whatever it is. But Julie came for the results. And at that point I was like really bought in. When we went there, Julie went and like we often do, just, Julie took really diligent notes, and I just kind of like took it in. And then we kind of had a plan, and simultaneously it became very clear that I needed to go back to being a data scientist at someone else's company. And so that became our objective. So it was kind of perfect timing in that regard, because I think that cognitive rehab went the best for me when we had a clear objective.
The interview format was very hard for you.
The interview format, because the way these interviews are structured is trying to stress you out. And as my testing will tell you, if I'm stressed out, it's not going to be good. So it became the strategy became, how do we keep from getting stressed out in the first place? And that was by basically somewhat structuring the unstructured. And I think that it speaks a lot to the process that, the stuff that I'm being asked is very specific, and, it's very mathematical. But we came up with a framework that we met every week, and I said how the interviews went that week, and we learned from it. So we already were starting to build out a script. And when I say this, I mean very literally. I would pull out my laptop during our meetings, and we would work on a document and kind of go through how this went. And Dr. Jamora watched this interview with me, and it was like 30 or 40 minutes of me being interviewed. And I think that was like the single, it's hard to say, but it was a very constructive session. She gave me very specific feedback that I basically integrated into the document. Like, let's get to the next stage. Keep the tangents out of it. Keep these other things out of it. Really focus on the skills. Say less, which is not my personality. And so basically, like, kind of coming to terms with that was the turning point. And I could not have done it on that time frame without the script and all of it.
And so after that, you were able to land a job?
Yeah, I got a job, and I've since gotten another job. I used the script. I went through another job search this summer. I would not be fully truthful if I said this was like a resolved issue, but like accepting the fact that I need help is something that's ongoing, because, to get a gross total resection of a grade 2 it's in many ways a very good situation to be in. But like, it's still brain surgery, and it's still, brain cancer.
So Julie, from your perspective, what was the cognitive therapy like?
And how did hearing the results affect you and your relationship?
We got these results and it was a bit shocking. He got really low scores on certain things. And one of the main things was that he just really wasn't able to process information that he heard at all without seeing it written down. And that definitely helped me understand more what Dieter was going through and how to best communicate with him. We've shifted a lot of things at home based on that, and it makes things a lot easier. I think that, like changing to just writing things down or texting him, or we have an app that we use that's one of those boards where you put all the things that need to get done on. It was scary getting that news. Actually, we were pretty upset because we had just gotten through the surgery and it had gone well. And so we're excited about that. And there's sort of a lot of external pressure or expectation that brain cancer is going to be like other cancers where you have it and then it goes into remission and then you can kind of like get over it. And this was more of a point where we were told, look, this is something permanent that you're going to have to figure out how to adjust to. And I think we were hoping that we could kind of move on, and it doesn't mean we can't, but it was shocking then. It took some adjustment. Dieter and I had kind of intended to have more of and do have more of an egalitarian relationship, and that had been important to us. It conflicted in a way with this value that I had and that we had in our relationship. And then on the other hand, I was kind of thinking about, to what extent am I getting frustrated with him for something that he can't control? And I think we just had to talk about all of those things and be able to adjust to them.
It's very tempting to be like, I don't have to do chores anymore. But like, that's not what we're going to do. Like, that's not acceptable. So I think that
Dieter tries really, really hard.
Yeah, and I think that what works for us is just regularity. So like, obviously, if I have decline when I get stressed, the way to not get stressed is to have a schedule and do things ahead of time and stick to the schedule. And like, Dr. Tumor always talks about systems. Like, you need to have systems. So like the things I do, I just do regularly. You know what I mean? Like, just clean up like every day, things like that. I'm responsible for, things like paying rent. I just make sure I mail it. I set it, I make sure it's on my calendar. It's written on my board. And just, I do that regularly. And as long as you're regular with these things, it's going to go a lot better. But if something flares up, it's going to be harder for me. That's another difference, is like when you have surgery, it's like, this is something that's going to happen this day. And everyone can, think, okay, it's going to happen this day. You're going to get to leave the hospital a couple days later, and then surgery's done. But with something like cognitive rehab, it takes a really long time, and you're not going to get back to where you were. Where I got a little bit private about what was happening in cognitive rehab, or like the results of testing, is people often want to say, like, oh, I have that too. Like, I'm sure people do. Like, everyone would benefit from these systems. It's just that I can't do my job without the systems.
Yeah. How about for you, Julie? Anything you want to add in terms of like how you're seeking support and what is helpful for you in all of this?
One of the things that we've sort of a big change that we've had would be that we don't do a lot of things that we used to do, like go out to restaurants or things like that, or be in big groups. But then there have been a lot of people who have sort of adjusted to our new lifestyle and are supportive and help us have fun. We have a lot of like sort of more intimate dinners with our friends, or we go on walks and hikes and things like that. And So that's really fun. I mean, we have a lot of support in each other, really, especially being young, sometimes young for this particular disease, I think, and for disease in general, I guess. It can feel kind of like you're alone in it because other people are sort of in a different life stage than dealing with grave illness. And so I think that we've gotten a lot of support around that. Now we have more of a network of people, and also we try to be there for people who we know who are young, who end up having some illness. And so I think that's been really helpful. I really liked their caregiver group and the individual therapy that I have. There's a lot of sort of unusual grief around brain cancer and sort of the changes that it might impact your life. And so I think that it's really helpful to have people talk to you about that and have people who are going to support you in that.
Beyond cognitive rehab, were there other services or programs that you have found helpful for you?
So I really like the survivorship group. It's always nice to meet other patients. Additionally, I went to the nutrition course with Dr. Abrams.
Yes.
And like that was, I mean, one, meeting the people was just incredible and getting to see them. That's been super helpful. And I feel really good having done that.
I guess I would tell someone that it's a long-term process, like someone who is sort of soon out of surgery, that it's a long-term process and that progress does happen. I mean, Dieter's still making so much progress now, and we're whatever we are, 2.5 years later.
I just wouldn't, I mean, I don't know how I would have done it without Julie. You know, when my world was turned upside down, I had Julie as my rock, and I knew, you know, obviously that I trusted Julie, and she really carried the family.
So I think that's all the questions I have. Is there anything else you want to add for the record, or anything else you want to?
I don't know. No, we really appreciate, you know, everyone who's trying to support brain cancer patients, and we appreciate you, Naomi, inviting us to talk today. And yeah.
Well, thank you again to Dieter and Julie for sharing with us what cognitive rehabilitation was like for you and helping us understand. So just to summarize, what I'd like to do is just present some patient-facing best practices that we've learned from people like Dieter and others as we develop our neurocognitive program. So this might seem somewhat simple, but I'm going to share it with you anyway, because it's always good to repeat some of the best practices so we can all learn. So clear information and materials on what to expect. So we really found that when patients were considering cognitive testing, it was kind of daunting to them. They were feeling already like they're not sure if they're going to be able to handle it. So we felt like it was really important to normalize that the testing is meant to be difficult in order to find the upper limits. And that seems to really help patients be like, okay, all right, it's going to be hard. And just to kind of know that, and to know that it's going to be hard for anybody going through this type of testing. We also just wanted to assure them there's no test preparation needed. It's a long, 3 hours, Dieter said. It's okay to bring snacks. So just those things were really helpful in just getting patients to feel comfortable coming in for the testing. And this probably doesn't need to be said, but I'm going to say it anyway. Reminders are crucial for everyone, really. It's best practice, but specifically for this population, a day before and an hour before. If it's a Zoom visit, an hour before is also very helpful. You heard Dieter talk a little bit about regularity, and that is also helpful then when you design programs. Can you make it a regular time? Where our Thriver group is every Thursday, except for today because of the symposium, but it's every Thursday usually. And if you can do clinical times, come every week at this time, that's really, really helpful for patients. Relay verbal information at an appropriate pace. So speak slowly. Sometimes it's helpful to sandwich your discussion with patients. So saying, I'm going to now talk about this, and then tell them what you're going to say, and then say, okay, now we've talked about that, let's talk about this. So just to kind of slow down the amount of information coming at people is helpful. Offer notes or a recording of a discussion or class whenever possible. You heard from Dieter that he had Julie to come in and take notes, but that's not always the case for our patients. Include visuals and white space on any printed materials. And include the caregiver when possible. You saw that Julie was really Dieter's rock, and that's really the case for all of our patients. So it's important to involve them and include them, and we're going to hear more about that later. But I also think it's important to create spaces for survivors to connect individually with each other as a group and individual. You heard that was important to Dieter, and it's really something we find valuable in our program. With our programs, we offer multiple access points, which leverages multidisciplinary care. So we try to have communication, and among our providers, we have an exercise physiologist as part of our team. We have our integrative oncologist. We have our nurses and neuropsychologists. So we have a lot of kind of eyes on patients, and any one of those eyes can be kind of an inroad to patients getting support and help. And it's really important, as you know, this is a fluid disease. The patients will say they have good days and bad days, but it's important to be expansive enough to encompass these changing needs. You don't want to have to create new programs, people leaving certain programs and going into other certain programs or services when they progress or when they're kind of feeling worse. So we have our Thriver group, for example, is broad enough to say, hey, if you're not feeling great, just come anyway. Sometimes you might need support, sometimes you can offer support. And we're also going to hear more in the next presentation about how we are expanding our Neurocognitive Clinic for our survivors. So with that, I want to thank you, and I want to now, we're going to dive deeper into how we've expanded the Neurocognitive Clinic to support all patients. And I'd like to turn it over to our survivorship program nurse, Alexa Greenstein. She oversees our nurse-led cognitive care management service for patients and caregivers.
So thank you so much, Dr. Chang and Naomi, for the introduction. It's a real honor and pleasure to be speaking on this panel. I'm excited to talk to you today about the Neurocognitive Clinic, a program I've had the privilege to help develop. It's been an exciting couple of years, and we wanted to share a little more about our program. So anyone who has cared for a patient with a brain tumor knows that this patient population is very diverse, and there is a spectrum of cognitive changes that can occur as a result of a brain tumor and its treatment. And these cognitive challenges may not always be present or immediately noticeable at time of diagnosis or after treatment. What we have observed and learned from clinical practice is that cognitive needs change throughout the disease trajectory and account for major decrements in function and quality of life. It is also important to recognize that patients are part of a family system, and cognitive challenges not just affect the patient with the disease, but those around them. Numerous studies have consistently found cognitive challenges can lead to significant levels of distress, fatigue, and burden for caregivers. The caregiver oftentimes plays a major part in managing the long-term cognitive and behavioral challenges, and yet often inadequately equipped to take on this role. As we have heard from Julie and other caregivers, it's really hard to understand and be prepared to manage the cognitive, behavioral, and personality challenges that accompany this disease. Caring for patients with impaired cognitive abilities can be stressful, challenging, and certainly isolating. As patients live longer with cognitive sequelae from brain tumors and treatment, we anticipate increased demand for cognitive support for patients and caregivers. Cognitive rehabilitation remains a promising intervention to address this, which has been highlighted in prior conversations as well in this video that we just showed. By participating in cognitive rehabilitation, Dieter was able to move forward despite his cognitive challenges and was able to return back to work, which was his quality of life goal. It's nice to hear these success stories, but as Dr. Wire-Jamora previously discussed, cognitive rehabilitation is not a one-size-fits-all, and that some patients, especially those with more serious cognitive challenges or those who are medically or psychiatrically unstable, may not tolerate structured cognitive rehabilitation intervention. And it may also not relate to the patient's health-related quality of life goals. I'd be also remiss not to mention the unfortunate reality is that brain tumor patients have unique needs which are often unmet with existing resources. So as we were building out the Neurocognitive Clinic, we asked ourselves, how do we go about expanding the depth and breadth of cognitive services to support the patients and caregivers we serve at UCSF, knowing that there are challenges and considerations for cognitive rehabilitation? So committed to wanting to find more impactful ways to provide sustainable cognitive support that would expand access to a more diverse population, we looked to the literature for guidance on how to practically implement a brain tumor specific cognitive support service within our department. Then we sat down and looked at the expertise of our group to see how to best address this need with the resources that were accessible to us. We realized we need to be more flexible in our approach to managing cognitive care, beginning with clinical implementation. Understanding the physical, emotional, and social impacts that stem from cognitive challenges and how this affects the family system calls for a more biopsychosocial holistic approach to cognitive management, which has been acknowledged by others today. By paying full attention to the whole person, not just the disease or cognitive symptom, allows providers to meet patients' unique needs while honoring their preferences and beliefs. The idea of caring for all aspects of a person is not a foreign concept for nurses. Advanced practice providers and nurses have not historically taken too much lead in the area of providing cognitive rehabilitation. However, these clinicians are equipped with skills to play an important role in the way of caring and managing, supporting patients and caregivers from both a practical and clinical perspective. As noted by earlier presenters and studies in the literature, there are considerations to factor to ensure patients effectively benefit from cognitive rehabilitation intervention. Advanced practice providers and nurses can work together with rehab specialists and referring providers to ensure appropriate timing, delivery, and content of therapy for each individual patient by uncovering potential contributing and reversible causes of cognitive impairment through screenings, interviews, and chart reviews. This can help provide key information to assist with planning of ongoing care and referrals to specialist teams. They can also assess a patient's readiness to engage in cognitive rehabilitation and potential barriers to care, help integrate behavioral management strategies from a dyad perspective, and identify and manage unmet psychosocial problems. And nurses are also well positioned to collaborate and with other healthcare disciplines to assist with program development, care coordination, and resource linkage. Their expertise as educators is also valuable since patients and caregivers often require tons of information about the disease to better understand and manage their wellness. Nurses can also assist in delivering health promotion strategies. Having many years of frontline neuroscience nursing experience combined with my advanced practice nursing knowledge made me uniquely positioned to serve as a change agent within our department to inform and infuse a more holistic approach to how we manage cognitive care for our patients. This paradigm shift gave birth to the development of the Cognitive Care Management Service, an advanced practice nurse-led initiative to complement the existing Neurocognitive Clinic, both in assessment, management, and consultation. And so the cognitive care management, what does this look like? So services were designed to provide more integrated cognitive care to better meet the needs of patients with more advanced cognitive challenges, with the goal of optimizing the quality of life for both the patient and the caregiver. The service is designed to provide practical and emotional support to the dyad, where emphasis is on adapting and coping with cognitive challenges and disability, opposed to the more traditional cognitive rehabilitation efforts offered by neuropsychologists Drs. Wire, Jamora, and Bray, directed at restoring discrete cognitive functions with emphasis on specific goals, as seen in Dieter's case. And so some examples of the tailored practical interventions and tools that are used in the cognitive care management service are, coaching and supporting patients and caregivers to adapt external compensatory strategies to improve attention, time management, and organization, such as keeping calendars, checklists, notebooks, counseling on stimulation precautions, and knowing how too much information and or sensory overload can become overwhelming for patients. Working on environmental modifications to eliminate or minimize distractions, assisting with supportive and communication strategies, for example, role playing and modeling paced speech, exploring different communication modalities, understanding that not all communication is verbal. Some other ways, since the involvement of the caregivers and family is crucial for patients and cognitive challenges, especially those with severe impairments, focusing on training and supporting caregivers remains a promising intervention. Coaching caregivers to develop behavioral management skills such as errorless learning, prompting, cueing, backward chaining, modeling have been found to be extremely helpful for patients to learn new information and maintain skills. And we brainstorm and strategize with caregivers to create and sustain environments that enables patients to maximize their function. We address sleep and disturbances and working on activity pacing and fatigue management strategies. Health navigation by connecting patients and caregivers to both internal and external resources. And plenty of education, lots and lots of that. And so many patients, experience psychological distress, mood issues, and suffrage as a result of disease. And as previously mentioned, caregivers often also report significant burden and distress. A really important thing I wanted to point out, Julie mentioned in the video that there's this unusual grief that is often accompanied by this disease. Caregivers face so much uncertainty, role overload, and isolation. And some of the ways in which we offer emotional support to caregivers and patients is by creating a very therapeutic relationship with them, actively listening and attending to their individual concerns and needs. Certainly validating and ensuring their emotions has been helpful too, and building and cultivating resilience. And other ways include focusing on bolstering strength-based coping strategies, whether that be problem-focused, emotion-focused, and seeking helpful resources to enable mental and emotional wellness. And helping to identify and change maladaptive thought patterns, by promoting self-talk, positive self-talk, and focusing on personal health maintenance, like assuming pleasant activities, hobbies, employing sleep tips, exercising, stress reduction strategies, and mindfulness. So cognitive support should occur across the disease trajectory, even with advanced stages of disease. As we know, cognitive challenges have a deleterious impact on patients and caregivers alike, with their physical, emotional, and social well-being. And efforts to address a high need in a setting of great scarcity calls for more integrated, novel approaches to address a growing unmet cognitive needs support. So enhancing and diverging traditional models of cognitive rehabilitation may be of interest in serving the individual patient and caregiver needs. And for those who are working with patients and caregivers who may not have access to as many resources as we are so fortunate to have at UCSF, thinking about leveraging the roles of your team members and the role of a nurse or an advanced practice provider when meeting the cognitive behavioral needs of brain tumor patients may be a novel approach and future direction for brain tumor cognitive care. And as mentioned by many of our presenters, given the complex and multifactorial nature of cognition calls for a team approach. We've heard this theme time and time again, but really putting into practice using evidence-based informed interventions and as a team sport, and really tailoring to the unique needs of patients and caregivers has really allowed us to harness our collective expertise and be able to provide a more comprehensive cognitive support service, which has extended our reach to better serve patients and caregivers. And with that, in a relatively short period of time, we're extremely proud that there has been so much growth in this program. It has gone from a relatively non-existent part of the neuro-oncology care to having now a complete service that is more comprehensive and more holistic in nature. But we still have a lot more work to do when it comes to meeting the needs of patients with brain tumors. We're making good headway and hope to continue to make an important contribution and dent in improving the care and management for this disease. So now I'm going to turn it over to my colleague, Margaretta Page. Margaretta is a nurse who has been within UCSF Neuro-Oncology Clinic for almost 30 years. And for the last 7, she has co-managed the Neuro-Oncology Gordon Murray Caregiver program with Dr. Suzanne Chang. Today, Margaretta will share her perspective on the impact the Neurocognitive Clinic has on patients, families, and the UCSF Brain Tumor Clinic.
Hi, I am one of those people who has been at this work in this particular setting for a long time. And I think I can testify to the fact that adding the Neurocognitive Clinic to the menu of services that we offer at UCSF to our patients has had a very positive impact, both on our clinical team and on the quality and the depth of the care that we've been able to offer our patient and caregiver dyad. And so it's with that perspective, really, from someone that's been here before the Cognitive Clinic existed to now, that I'd just like to make a few closing reflections about the impact that adding this clinic has had on our care. So a neurocognitive clinic really does meet a need. I think all of us have heard, historically, it's been a challenge, actually, as a provider to address the cognitive and the behavioral challenges experienced by this patient population. And as many of you know from your own experience, that the specialized resources to meet these needs remain relatively limited. At UCSF, we could often find testing, but there were few, if any, therapists who were in the business of taking the information that they gleaned from that therapy, from that testing, and then building a rehab or an optimization strategy that was specific for brain tumor patients. So really for us, beyond helping patients and families understand that it was the tumor or maybe the subsequent treatments that were the cause of their cognitive, personality, and behavior changes, and perhaps maybe sharing a strategy that it anecdotally worked for others, we really had little to offer our patients and families. And so patients and families were left to rely on these strategies that were designed actually for patients with other illnesses, and sometimes we're having to sort things out on their own. So the Neurocognitive Clinic definitely improves the provider expertise and enhances our care. Adding this clinic to our service has actually enhanced the expertise of all the members of our care team, really around managing the cognitive and behavioral symptoms that our patients experience. Members of the neurocognitive team have offered our clinical team education so that all of us can now offer really evidence-based frontline strategies to our patients and families who present with cognitive and behavioral symptoms. For example, physicians and nurses can make a recommendation for exercise counseling, or can share tips on maybe ways to reduce distraction, or use some of the information sheets and education that we've developed around fatigue management, sleep strategies, and stimulation precautions, just to name a few. All of these things which are known to help with cognitive and behavioral management. So we have weekly multidisciplinary meetings that focus on our patients and caregivers, and they allow for this really rich bidirectional consultation among our team members. And the leveraging of this expertise amongst specialties has really been critical to help elevate all of our team members with the knowledge and understanding on how we can best support our patients and families. And these, in addition, these meetings facilitate really a continuity of care across all providers. The Neurocognitive Clinic adds a layer of support. So in addition to what we've been able to offer before, this has really helped our program meet the needs of our patients like Dieter in a much more comprehensive way. And it has been able to offer our caregivers even another layer of support with really in-depth education and information on the symptoms, management strategies, and as Alexa mentioned, this very tailored emotional support around the invisible losses and changes that our caregivers are experiencing. And as Chris and Naomi and Alexa described, the Neurocognitive Clinic is able to offer really individual and dyad support across the entire disease trajectory through one-on-one direct consultation and this variety of programming that we have available to our patients and families. A Neurocognitive Clinic extends the reach of our caregiver program. Certainly at UCSF, we created the Gordon Murray Caregiver Program 7 years ago to provide support to the caregivers of our patients. And it's well documented that our caregivers struggle not only with the need for information and practical strategies to assist our patient, but with these tremendous feelings of loss and isolation and grief over the cognitive and the behavioral challenges that the patients were experiencing. And the Neurocognitive Clinic has really extended the reach and the depth of caregiver support that we're able to offer at UCSF. They offer neurocognitive patient assessments and follow-up care that includes ongoing caregiver support and dyad interventions. So together with the caregiver program, the Neurocognitive Clinic really works to address those separate and different needs of our caregivers. We share cases weekly, we seek transdisciplinary input, and we suggest strategies so that all members of the health team are supporting the health and the well-being plan for the dyad in a really congruent way across the illness trajectory. A Neurocognitive Clinic benefits from philanthropic partnerships. And so I'd just like to take another moment to acknowledge our generous supporters and our really just amazing partners who have shared our vision and believed that we could do this and really help make it possible. So I'd just like to acknowledge the Sheri Sobrato Brisbane Foundation, the family of Christina Caporo-San, the Low Glio Consortium, the UCSF Helen Diller Cancer Center, and the Gordon Murray Caregiver Program. And it's support from our partners that's really allowed the UCSF Brain Tumor Center to be innovative and creative in our program development and the services that we offer to our patients and families. So today I just want to leave you, I think, with maybe the most important message, that the UCSF Neurocognitive Clinic improves the quality of care. Practitioners are able to offer evidence-based interventions for cognitive support, whether it be right there in their clinic or make a referral over to the neurocognitive service. Together, we're able to support the dyad, first by addressing the similar needs that patients and caregiver have, as well as the separate needs. Second, cognitive support that's offered by providing information, this variety of cognitive strategies, and the emotional support really does facilitate positive coping and adaptation to change for the patient and the family. And finally, I think the most important aspect of this clinic is that it does optimize the quality of life of our patients and their caregivers. This clinic gives our patients and families really a chance to lead their best life possible, no matter where they are on the disease trajectory. Thank you.
Thank you so much, Margareta. I think that was a nice opportunity to hear the patient perspective. I think that video is very valuable for all of us who are caring for patients, even on a day-by-day basis, just to give them some space to talk about their experience.